Hi there, I'm Dr. Faisel Syed. This is my first live not LinkedIn. I gotta get my social media right here. This is my first live Instagram. And I hope it's gonna be the first in a series called Healthcare 101. There's a lot of misconceptions right now in healthcare in general, especially that has been brought to light with the coronavirus over the last 4 to 5 months. So basically, from the beginning, I'm gonna kind of establish where we are as a country with healthcare today. I'd also like to talk about a completely different way of practicing medicine, and I'd like to then open it up to questions that anyone has. So from the beginning, let me just introduce myself. My name is Dr. Faisel Syed. I'm the National Director of Primary Care for ChenMed. ChenMed is an organization that is a primary care organization specifically for seniors. Our average senior is about 72, 74 years old. They have anywhere from 5 to 7 chronic medical conditions, and they're all living on fixed incomes. So we have practices right now located in 10 states. We'll be opening in several more over the next couple of years, but that's sort of my background. And now, let's get started. Anybody have any questions right before I get started? Okay, so here's the state of the country today. Currently, we have about 330 million Americans. The GDP for the country, $17 trillion. And out of that $17 trillion, for 330 million people, we spend almost $4 trillion just on healthcare. And if you break down how we're spending money on healthcare, for people who are over the age of 65, we spend over $1 trillion for people over the age of 65. Now you may be wondering, well, that's because we have so many people who are over the age of 65. In fact, we only have about 15% of our population who are over the age of 65. The truly medically complex. So when you're talking about people over the age of 65, out of 330 million people, we only have 45 million people who are over the age of 65. And for that population of people, we spend over $1 trillion for their healthcare. And if you're thinking about the whole pie of $4 trillion, $1 trillion is spent for people over the age of 65. And now, another piece. The average American is only 38 years old. How many of us have heard that, well, there's a primary care shortage, there's a primary care shortage? Well, if you're talking about the ability of impacting health, and you're talking about a relatively young patient population, how much medical attention is required for active management of your typical average 38-year-old? If you're waiting for a problem, then a lot more actually, than if you're preventing, and if you're talking about educating and prevention of disease. And so, now, with the $4 trillion that we're spending on healthcare, it is very, very well documented, and this is going back decades, looking into how many medical procedures are unnecessary, or what we like to call in healthcare, it's waste, meaning that it didn't need to happen. And there are several causes of spending money unnecessarily in healthcare, but there's one main driving cause of waste in healthcare today, and that is unnecessary hospitalizations. What do I mean by that? I mean that a hospitalization that is happening for a patient that could be totally managed in the outpatient setting if the patient had access to a primary care doctor or outpatient care in general. With unnecessary hospitalizations, and unnecessary hospitalizations first start in the emergency room setting. And when we look at emergency room setting, in the country, half of all medical care right now is delivered in the emergency room setting. And if you look at the cost of delivering medical care in the emergency room setting versus the cost of delivering the same healthcare or similar healthcare in the outpatient setting, it is not a difference in a matter of 10 times or even 100 times. It can be up to 1,000 times more expensive to deliver the same medical care or similar medical care in the emergency room setting rather than the outpatient setting in the primary care office setting. Let me give you an example. 2 years ago, I had pneumonia. I was sick for a couple weeks, and I didn't have any of your typical symptoms of pneumonia either. I didn't have the cough, I didn't have the fever or the chills. I had progressive weakness over the course of 2 to 3 weeks. And at that time, it was in November, 2 years ago. We had a very nice vacation planned for the end of November with my in-laws. It was their 50th wedding anniversary. And so I remember telling my wife, I just got to push through these next couple weeks. I must just be exhausted. I just must have been working too much. And I sort of let it go too long. And finally, one night, my temperature was bouncing between 104 and 106. And it was early in the morning hours one morning where I told my wife, I actually felt myself hallucinating. And I said, okay, I probably better go to the urgent care. And outside of our neighborhood, there's what's called a standalone emergency room. Now, standalone emergency rooms are popping up all over Florida. And they basically, if you just look at it, it looks like an urgent care. But effectively, it's actually registered as an emergency room that is not attached physically to a hospital. So they can then bill at emergency room rates, which is something I didn't realize when I went there to get care, because at the time I desperately needed someone to take a look at me and let me know what was going on. When I was there in the emergency room, I had the typical sort of workup that anyone would do when you're faced with at the time I was 39 years old, showing up with the symptoms I had. I ended up having some blood work done, a chest x-ray, and so far as treatment is concerned, I was started immediately on IV fluids, which we call normal saline IV fluids, and I had received Tylenol, acetaminophen, to try to bring my temperature down because I had a high temperature. The chest x-ray results, even before the chest x-ray results came back, I knew what was going on with me because I looked at the picture and I saw I had a pneumonia in my lung. And so they gave me two different antibiotics, which is pretty typical for someone who has an infection like that. You'll get an injection antibiotic and then an oral antibiotic. And within a couple hours, I was sent home. Shortly after that, we got the bill. Now, who can guess how much that bill was for those couple hours while I was in the emergency room? I guess we could use the chat feature here if anybody wants to take a guess with how much it cost for me to receive that treatment in the emergency room setting. Because I think it's important to understand. And I can just let you know. So the cost of delivering that care in the emergency room setting, the insurance company tried to bill, it's a lot. The insurance company tried to bill over $10,000 for that ER visit. In the ending, my insurance company ended up paying $6,800. So I took the bill to one of our clinics, to the center manager, and now in the world that we practice, we don't deal with billing. What we do in our world is we practice what's called value-based care. And with value-based care, we receive all the premium dollar, or most of the premium dollar, upfront ahead of time. So in many ways, we work like an insurance company, and we know how much the cost of care actually is. So I went to my center manager in the primary care office, and I said, the treatment that they gave me in the emergency room is treatment that we do here in the clinics. How much would it cost if we did this in the clinic? So she went through and broke it down. She said, well, they did an EKG, which I forgot to mention. Yeah, they did an EKG, which is sort of standard protocol with that. And we do that in the clinic anyway. It's done with the machine. The machine spits out the EKG, and then the doctor interprets it. So we don't charge for EKGs. And they did a chest x-ray. In the clinic, again, we do that internally. We have the machines here. We do it. It's all done digitally. It's read internally by a team of radiologists remotely. So he said we don't charge for that either. And the acetaminophen, the Tylenol, cost less than a penny. The two different antibiotics they gave, one of them cost like 50 cents. The other one cost like 70 cents. And she was like, yeah, basically, Dr. Syed, the cost of this at our clinics is less than $7. And I was just blown away because the bill that we had, that the insurance actually paid for, was almost $7,000. So literally, it cost 8,000 times more to get the same treatment that I had that I could have had in the outpatient setting than getting it done in the emergency room setting. And the thing is that so far as that difference in the cost, many people don't know that, including physicians, including myself. I had no idea that it would cost almost $10,000 to get a couple hours of treatment in the emergency room setting. I had no idea. And that's as a physician. And the irony is, I have several of my friends who are primary care doctors who moonlight in the emergency room or moonlight in urgent care, offering the same treatment. And the thing is, and this is the thing that many of us, never realized, the cost of giving the same care by the same doctor can be vastly different based on the setting. So it's important to understand that when we're talking about what the current state of healthcare is in the country today, it is fee for service. And now fee for service represents 95% of medical billing in America today. What does that mean? That means that there is a transaction or dollar amount tied to every encounter with the healthcare system. And that's either with a doctor or with even seeing a nurse or anyone that's involved with a healthcare setting. There is a dollar amount tied to it, billing codes. And that's 95% of healthcare in the country. So it's important to know that, yes, you may be going to see a doctor and there's a $10 copay or $100 copay or whatever the copay is, or there's a deductible. The amounts that are charged are independent to each place you go to. And they can charge you pretty much based on whatever they want, whatever they feel justified. And you can imagine that in the current system, if I brought up the concern that, hey, how come you're charging me $7,000 for a pneumonia treatment in the emergency room setting when we can get it done for $7, or really the cash price for any 2-view x-ray anywhere in the country is about $15. So you could say make it $20 or $25. The same treatment in the outpatient setting, the response from the hospital or from the emergency room would be the same. They'll say that, well, it was an emergency setting. We feel justified charging what we're charging for people in the emergency room setting. And I would pretty much respond back saying, well, I guess you're right. I guess you're right. Thank goodness I have insurance. But then what happens to the people who don't have insurance? How many people don't have insurance in the country with this current system? And in the current system, about 30 million people don't have health insurance. And even more important than that, well, that is an issue in itself, which is really quite important. There are 40 to 60 million people who are underinsured, meaning they can't afford their copays or their deductibles. And yes, they're covered in case something catastrophic happens. But what good is insurance if you can't afford the copays or deductibles? Will you take action to prevent a problem from happening to begin with? Or if you start having some issues, you nip it in the bud early? Probably not. So the system encourages a big chunk of people to wait for a small problem to become a big enough problem where you need emergency treatment. And then the system, the fee-for-service system, can then justify billing as much as they're billing. That's how come we're spending, actually, compared to any other developed country in the world, we spend about $12,000 per American on healthcare, which is literally twice that per capita compared to any other developed country in the world. And I believe that the main driver of that is because the current system incentivizes this fee for service, this transactional billing system, where the incentive is to generate revenue. So let me put it in a different perspective. If we have a bad flu season and the local hospital is full with patients because of having complications from the flu, the hospital is going to make a lot of money. So would the hospital make that money if the patients were staying home or being treated by their primary care doctor or team of doctors in the outpatient setting? No, they would not, unless they own those practices. And then those practices then feed in to the hospital system. So you see, the current system incentivizes that. It incentivizes patients to be treated at the emergency room or hospital setting. I hope that made sense. Does that make sense? Anyone who's listening? And does anyone have any questions? Now, I see there's no questions. So I'd like to keep moving forward. I'd like to wrap it up for today. I hope you understand at least where we're at with healthcare as a country today. And I'd like to talk with you about value-based care, a completely different way to practice medicine. And this is how we practice medicine at ChenMed. We're actually scaling out a completely different way of practicing medicine where there's no billing involved. We have clinics currently right now across 10 states, and we don't even have a billing department. and it completely changes the way that you practice medicine. So thank you for joining me today. I hope you found it informative. I look forward to doing this again, hopefully next Friday. Thank you. Take care.